Again, thank you very much for the invitation to speak with you all again this year. It's been a great pleasure coming to Durban for many years now, and I'm going to switch gears and talk about something boring and old to you instead of something exciting and new, but hopefully will provide you with some new comments about antiretroviral therapy. So this is just summarizing the outline of what I hope to talk about this morning. The evolving global epidemiology, not just of HIV, but of antiretroviral therapy. What's new in the guidelines? What's new with some newer drugs and regimens for antiretroviral therapy? Some information about some investigational drugs that are coming into phase 3 testing and are likely to be available in the near future. And talk a little bit about where I see antiretroviral therapy going for the future as we move forward in the HIV epidemic. So you've seen lots of pictures already this morning, and thankfully my preceding commentators have already highlighted a lot of this information. But based on WHO data through 2015 now, we know that there are almost 16 million people in the world accessing antiretroviral therapy. And this is an important statistic because it obviously represents the number of people on antiretroviral therapy according to what the national guidelines and the WHO guidelines have been up to this point. And that's likely to change in the very near future. You've also seen examples of the impact of antiretroviral therapy on total life expectancy, with the WHO estimating that between 2000 and 2014, during the scale-up of antiretroviral therapy worldwide, there have been about 8 million deaths averted by just with the initiation of antiretroviral therapy, such that we're seeing a tremendous decline now in the overall mortality rate associated with HIV. And that has had a dramatic impact on HIV life expectancy, not just in South Africa, as you heard from Stephen Chang this morning, but in many countries throughout sub-Saharan Africa, what had been a very dismal decline in life expectancy as a consequence of the HIV epidemic has literally reversed in nearly all of these countries, South Africa included. But that message, as Stephen Chang also highlighted, and as several of our speakers this morning have highlighted, is taken with a little bit of concern in terms of the treatment cascade. And this is a representation also published in the most recent global report from the WHO of people living with HIV. And looking at this graphic, you can see that only about 50% of people worldwide between the ages of 15 and 49 living with HIV actually know that they're HIV infected and are aware of their status. So that's still, while we've made remarkable progress there, there's still a lot of work to be done just with HIV testing and counseling. Of people who are living with HIV and knowing that they're infected, only about half of those are receiving antiretroviral therapy worldwide. And of those who are living with HIV on antiretroviral therapy, are only about a third of those are still on antiretroviral therapy a year into treatment, meaning that we're losing some people to treatment even after initiation. And then an equal number of individuals are living with HIV and virologically suppressed. Now, these kinds of numbers started emerging from the United States as well. In the United States, an area where we've had good antiretroviral therapy for 2 decades now, we still have maybe not such a problem with people being aware of their status. We still have about 20% of our population are not aware that they're HIV infected. But our status throughout the United States now also suggests that only about a third to 40% of the patients we have on of people living with HIV on antiretroviral therapy are virologically suppressed. And this differs depending on what part of our country you look at. But this tells us that we need to do a lot of work on the treatment cascade and maintaining people in care, maintaining them on therapy, and maintaining virologic suppression. And so there are a lot of steps that go into making sure that that happens. This is just another way that in the WHO UNAIDS 2015 report, concentrating specifically on low and middle income countries, the median ART retention rate, if you look out here at 5 years after ART initiation, only about 60% of patients are still on antiretroviral therapy. So we've had good success, but we also have ongoing challenges, and that's the setting in which I want to talk a little bit about new issues in antiretroviral therapy. So what's changed this year? Most of you are very well aware of the change in the WHO guidelines to suggest that ART should be initiated in all adults living with HIV regardless of CD4 cell count. That's a new recommendation, strong recommendation with moderately strong quality of evidence. And this also carries over into adolescents, although the WHO has given this a conditional recommendation with low quality of evidence, primarily because the majority of what I'm going to talk about in terms of testing has been done in adults. So what is the basis for this change in WHO guidelines? I think the move toward this began with the publication of HPTN 052, which was a large clinical trial done in many countries in sub-Saharan Africa and Southeast Asia that looked at 1,763 serodiscordant couples. And patients were the index patients who were HIV infected, and their serodiscordant partners were randomized in a clinical trial to receive early antiretroviral therapy at the time that they entered the trial, and that group of patients had a median CD4 count of about 450 up to 550 versus delayed antiretroviral therapy. And the median CD4 count here was 230 because it was delayed according to countrywide treatment guidelines at the time, and patients waited until their CD4 count fell below 250 to be started on antiretroviral therapy. And what the original study reported was a 96% reduction in transmission of HIV to the serodiscordant partner, but a corollary analysis from the HPTN 052 study were the clinical endpoint analyses in the individuals who were HIV infected and got treated early with antiretroviral therapy compared with those who had delayed initiation. And you can see that although these numbers are not huge, new onset AIDS events occurred in a lower rate in those who got early antiretroviral therapy compared to those who had delayed therapy, with a hazard ratio of about a 40% reduction in new AIDS-defining events. More importantly, for places that have a high endemic rate of tuberculosis, there was about a 50% reduction in the TB rate for patients who got started early compared to those who had delayed initiation of ART. And this is just graphically represented in this slide here, the number of primary endpoints, including mortality, onset of AIDS and non-AIDS events, and then specifically AIDS-related events. Following this, there were 2 more studies that came out just recently and have been published since the IAS meeting in which they were first reported. One was the Temprano study, which looked at 4 different groups: initiation of antiretroviral therapy immediately, regardless of CD4 cell count, and deferred antiretroviral therapy according to country guidelines, very similar to HPTN 052. But in addition, this study also, in a factored manner, included IPT as part of the factorial design, such that patients either got deferred ART plus IPT, immediate ART, or immediate ART plus IPT. And what they were able to show in this study was the 30-month probability of death or serious AIDS-related opportunistic infection or other illness. And this green arm graphic here is the deferred ART arm alone, having a 14% probability of death or serious AIDS event, compared to a 5.7% probability in individuals who got immediately treated regardless of CD4 cell count and received IPT as well. That study was also followed very quickly by the results from the START trial. And many sites here participated in the START trial, and you're aware that this was a randomized, very large randomized clinical trial done internationally that also looked at ART-naive patients, all with CD4 counts of greater than 500, who were randomized to receive immediate antiretroviral therapy or deferred therapy according to country guidelines. And the primary endpoint in this trial was a composite endpoint of serious AIDS or death from AIDS, serious non-AIDS events, and death not attributable to AIDS. And the serious events that they included in their primary endpoint were cardiovascular disease, end-stage renal disease, decompensated liver disease, and other non-AIDS defining cancers. And to make a long story short, there was a 57% reduced risk of serious events or death in the immediate arm, and 68% of the primary endpoints occurred in patients with CD4 cell counts of above 500. So clearly establishing the fact that even with very high CD4 cell counts, there were still serious events that occurred and that could be prevented with the initiation of antiretroviral therapy regardless of CD4 cell count. Other pieces of information that I think were very interesting that emerged from the START study is that those individuals who got immediate therapy after nearly 5 years of follow-up had still viral load suppression. About 90% of those individuals on antiretroviral therapy were still virologically suppressed. And this is a much higher statistic than we tend to see in people who start ART much later. And what you can tell also immediately from this graphic is that those individuals who deferred therapy obviously became virologically suppressed when they were on therapy, but at the end of 5 years, only about 70% of those individuals were virologically suppressed on therapy. And interestingly as well, the group that got immediate antiretroviral therapy had significant increases in their CD4 cell count, up to about the 900 to 950 CD4 cell count range, while those who deferred antiretroviral therapy to country guidelines, even though they started at 500 or greater CD4 cells, had overall a decline until they started on ART, but haven't even quite made it back to their original CD4 cell count when they entered the study. So a very dramatic difference in the immune reconstitution, if you will, that was achieved with early initiation of antiretroviral therapy. And this just shows you, again, the reduced risk of serious AIDS events, even in patients with high CD4 cell counts who started therapy immediately. So that's really the underpinnings of the WHO change in recommendations to start antiretroviral therapy in individuals who have regardless of CD4 cell count. And so I think the challenge for us going forward with antiretroviral therapy is this statistic here, making sure that people become aware that they're HIV infected and trying to implement the change in guidelines to include all HIV infected individuals initiating antiretroviral therapy is going to require extensive resource readjustment and consideration if we want to be able to achieve some of the important advances and health risk reduction that we saw with these studies. So I'm going to go on now to talk a little bit about newer antiretroviral drugs and how we might utilize them, even in the context of the resource constraints that may be imposed by trying to initiate ART in all HIV-infected individuals. And I think there's a uniform message that I hope to convey across several of these studies that I'm going to be discussing, and that is the proportion of individuals who both achieve and maintain virologic suppression when they're started on some of these drugs as first-line therapy. So the first set of studies I'm going to talk about are with dolutegravir. This is a second-generation integrase inhibitor that is now being given in countries where this drug is approved as a fixed-dose combination given once daily in combination with 2 NRTIs. And it was approved on the basis of these 3 randomized clinical trials. The SPRING study looked at dolutegravir plus 2 nucleoside reverse transcriptase inhibitors compared with raltegravir, the first-generation integrase inhibitor. The SINGLE study compared dolutegravir, abacavir, and 3-TC with a standard fixed-dose combination of efavirenz, tenofovir, and emtricitabine. And the FLAMINGO study compared dolutegravir with 2 nucleosides versus a boosted protease inhibitor regimen with 2 nucleosides. And the first of these studies, dolutegravir with abacavir and 3-TC, was clearly superior in terms of virologic suppression when compared to efavirenz, tenofovir, and FTC. And this superiority carried out to 144 weeks, with virologic suppression significantly better for the dolutegravir regimen, virologic non-response significantly better with dolutegravir, or significantly lower with dolutegravir, and looking at the plots here favoring dolutegravir at all 3 of the major time points in which the data were analyzed, at 1 year, 2 years, and 3 years post initiation of treatment. The FLAMINGO study compared to a boosted protease inhibitor similarly showed an improved virologic success with the dolutegravir compared to boosted darunavir, and this carried out also to week 96. And the analyses clearly favoring, these are the 95% confidence intervals, showing that the benefit carries through in both of these weeks in a statistically significant way compared to a boosted protease inhibitor. And then the comparison with another integrase inhibitor also showing dolutegravir, in this case, to be non-inferior, but the delta here being a little bit higher virologic success rate at 48 weeks and 96 weeks for dolutegravir compared to raltegravir, and this may have been primarily due to the higher rate of virologic non-response in raltegravir. The one key feature of dolutegravir that has been highlighted in all of these trials is that individuals who were virologic failures or virologic non-responders in treatment-naive populations being treated first line with dolutegravir, there were no treatment-emergent resistance mutations in individuals taking the dolutegravir. All the virologic failure that was associated with development of resistance occurred in the alternative treatment arms. And this has been an important key feature of dolutegravir and its use in treatment-naive populations. This slide is data taken from a clinic population in North Carolina, one of a very large clinical cohort reported at CROI this year by Joe Aron, showing, and it's a little hard to read the numbers down here, but I just want to highlight the colors in these last 2 bars. This purple color here is the proportion of newly diagnosed patients who are being initiated on ART with an integrase inhibitor-based regimen. And as of 2014, the majority of patients in their clinic populations were being started on dolutegravir and in a fixed-dose combination as a single pill with 2 nucleoside analogs. Well, why is that important? And I think that's important showing here their statistics in terms of the durability of their first-line regimens. When they compared patients who started initial therapy with an integrase inhibitor-based regimen, they've had a much higher rate of retention on first-line therapy with an integrase inhibitor-based regimen than with a NNRTI regimen containing efavirenz, than with a boosted protease inhibitor containing regimen with either atazanavir or darunavir or lopinavir, ritonavir, and certainly much higher than older regimens that were in use prior to this time. And the use of an integrase inhibitor-based regimen in first line was strongly associated with the ability to sustain virologic suppression and reduce the rate of treatment-emergent drug resistance mutations in their population. And so I think this is an important message that we're starting to see in developed countries that have access to integrase inhibitor-based therapy, is the tolerability of these regimens. The very high barrier to development of resistance has resulted in significant improvement both in virologic suppression and the ability to sustain that virologic suppression long term in individuals receiving these regimens. This is now being played out with an attempt to look at whether we can actually reduce the number of drugs that patients are being exposed to because of some of these unique features of the second generation integrase inhibitors. And these are results from the European conference this fall, referred to as the PADDLE study. And in this study, it was an open-label, single-arm phase 4 exploratory trial in which the investigators used dolutegravir plus lamivudine as a 2-drug regimen in treatment-naive patients. You can see that they had a fairly broad range of viral loads among these individuals. They started therapy when the CD4 count was high. They were all surface antigen negative because of the issue with hepatitis B negative, so as not to be exposing people who needed treatment to a non-tenofovir containing regimen. But the important point here being that in this smaller open-arm, single-arm open study, 20 out of 20 patients were fully suppressed at week 24. They were all virologically suppressed by 8 weeks of therapy, including 4 patients who had high viral loads above 100,000 copies. There have been no virologic failures in subsequent follow-up of these individuals, and no resistance mutations have emerged. Although, obviously, 24 weeks is a fairly short period of time for follow-up. So that's a clinical trial that is actually now being initiated in the US through the AIDS Clinical Trials Group, and there's a planned clinical trial for the AIDS Clinical Trials Group network to conduct this in international settings in sub-Saharan Africa and Asia. The next new drug I want to turn to now is a prodrug of tenofovir. You've all heard a lot about TAF, or tenofovir alafenamide fumarate, and there have been several studies that we've talked about here in MEPI symposia before, looking at whether or not this prodrug, and the particular characteristics of this prodrug are that it concentrates intracellularly and the serum concentrations of the drug are very low. The theory with the development of this drug is that by concentrating the drug intracellularly with low serum concentrations, you could avoid some of the toxicities associated with the parent drug, tenofovir TDF. And in this randomized, double-blind, active controlled phase 3 study in treatment-naive patients, individuals were treated with an integrase-based regimen that contained TAF or an integrase inhibitor-based regimen that contained standard tenofovir. These were fixed-dose combination single tablets that included elvitegravir and cobicistat to boost the elvitegravir, FTC, and either TAF or tenofovir. The results of the study showed that these 2 regimens were equivalent in terms of their virologic outcomes, with 90% of individuals at 48 weeks being fully suppressed in both treatment arms, and no equivalent numbers of virologic failures. The equivalence is demonstrated here. There were no significant treatment differences between the 2 in terms of virology. What was noticed in the study was what we expected. The renal and bone outcomes with TAF were significantly improved when compared to the parent drug tenofovir. There was a decrease, or there was improvement in glomerular filtration rate overall although it was a smaller improvement in individuals who were of African descent. And overall, in both populations, there was less spine and hip bone mineral density loss in the TAF arms. Another study that was also presented at the CROI conference just last month in the US looked at individuals who were already on tenofovir and were fully suppressed and randomized them to switch to a TAF-containing regimen. And in the study, fixed-dose combination of FTC and tenofovir or FTC and TAF were used with any other third agent that the individual happened to be on. So the only switch that was made here was substituting a fixed-dose combination of TAF and FTC for tenofovir and FTC. And as you can see, the virologic treatment differences were roughly equal, success rates in about 94% of individuals in both treatment arms, very little virologic failure, and nothing in terms of virology separating in the two treatment arms, suggesting that there was equal virologic outcomes in both arms. But more importantly, switching to TAF in individuals who had already been on tenofovir for a period of time improved glomerular filtration rates and improved bone mineral density in both the spine and the hip. This being the traditional tenofovir arm and this being the TAF arm, with significant improvements in both glomerular filtration rate and bone mineral density. So I think the evolution that has resulted from many of these recently completed clinical trials is a complete shift in our guidelines and the guidelines of the European Union to provide preference in first-line therapy for both integrase inhibitor-based regimens and for TAF replacing tenofovir in those fixed-dose combinations for which this is available. And this has been a consistent change across the guidelines recommendations in developed countries. I think as the costs come down for some of these integrase inhibitor-based regimens, and as TAF commercially emerges as a substitution or replacement for tenofovir, we may see both of these classes of drugs moving into treatment and care in sub-Saharan African countries as well. So in summary, randomized trial data clearly support initiation of ART in patients regardless of CD4 cell count, although clearly in low and middle income countries, there will need to be resources prioritized for those at highest risk. And as those resources are developed to treat all individuals regardless of CD4 count. The choices for initial therapy are clearly evolving as we develop better tolerated drugs that have higher barriers to emergence of resistance and are more potent in fixed-dose combinations, and those are likely to be seen in low and middle income settings as well as the costs for those agents come down. So I'm going to spend just the last couple of minutes talking about what's new with some novel investigational drugs, and talk first about why do we really need new antiretroviral drugs. I've just told you about developments in the field that have clearly shown currently available antiretroviral drugs are doing a very good job for most individuals. Well, we have much bigger goals. You know that the WHO has the 90-90-90 goal of getting 90% of individuals to know their status, 90% on therapy, and 90% virologically suppressed. That's a very energetic goal, if you will, but by 2030, the expectation is that those will be 95% at all levels and reducing the rate of new infections annually to less than 200,000. Those are real challenges. I've already talked about the challenge of the treatment gap. Obviously, treatment is going to be required if we really take this to heart and initiate therapy for any HIV-infected individual. You may be administering antiretroviral therapy for up to 8 decades, and that has a significant association with the potential for other toxicities. We already know about the renal and bone toxicities with tenofovir, cardiovascular and liver toxicities with some of the other antiretroviral therapies that are widely used. We also need better therapy options for infants, children, and pregnant women, and you'll hear about that later in this afternoon. We have significant challenges with adherence, life chaos, treatment fatigue, aging, and drug interactions, particularly where tuberculosis is a significant problem. And although I've said antiretroviral resistance in the dolutegravir studies has been minimal to non-existent, it's clear that as more use of dolutegravir comes into play, we are likely to see resistance emerge in some settings. And this has been seen with every new antiretroviral drug that we've developed. So I think there are plenty of reasons for us to need new drugs eventually. The other reason has more to do with the setting in which you all practice, and that is the global epidemiology of drug resistance after failure of first-line regimens. Current first-line regimens, even the ones that are newer, have not had such an important ability to sustain virologic suppression, primarily because of the lack of availability and access to viral load testing and subsequent second-line options in many parts of the world. And although you can't see the numbers here very well, these bars are representing the proportion of individuals that have key tenofovir mutations, NNRTI mutations in maroon here, M184V mutations, and combinations of mutations to all three tenofovir, NNRTIs, and to 3TC and FTC. And what you can see here is, regardless of what part of the world we look at, we have significant levels of resistance mutations in failure of first-line therapy to the NNRTIs, to tenofovir, and to the other nucleoside analogs. And that's the landscape in which we're introducing newer drugs. So the issue here is that even newer drugs that have a high barrier to resistance in populations where first-line regimens have been continued in individuals who are failing therapy, there's been an accumulation of significant resistance mutations that will substantially reduce the ability to have companion drugs to pair with those new drugs. So we do need new drugs that are active against drugs that have resistance mutations and that are better tolerated than the current second-line therapies available. So this is just an example of one of these. This is now what would probably be considered a third generation or fourth generation NNRTI, and doravirine being developed by Merck. And this is a week 48 study in treatment-naive individuals looking at virologic suppression in individuals who received doravirine plus tenofovir and FTC in a variety of different doravirine doses, and then in purple here, a standard efavirenz fixed-dose combination regimen. What you can see is that there's relatively similar virologic responses regardless of what dose of doravirine was received, and the virologic response rates at 48 weeks in terms of full suppression was greater than that seen with the efavirenz fixed-dose combination. So doravirine in this setting was superior to efavirenz. However, there were some differences based on the initial viral load for the populations that were started on doravirine, and suggesting that at higher viral loads, some of the doses of doravirine did not perform as well as was seen with efavirenz. In a study that was also presented at the CROI conference just last month, doravirine administered at 100 milligrams a day compared with efavirenz in a larger phase 2 clinical trial, doravirine and efavirenz response rates were roughly equivalent in terms of virologic suppression for individuals who had lower viral loads, but doravirine didn't do as well against viruses in individuals who had higher viral loads. The benefit of doravirine seen in the study, however, suggested that there were significantly fewer central nervous system or neurologic adverse events with doravirine. There were no treatment-emergent resistance mutations, and efficacy, even though it was modestly reduced at higher viral loads, was still substantial. So this is now being moved into phase 3 clinical trials and may ultimately be available as another newer regimen, fixed-dose combinations with a higher barrier to development of resistance than efavirenz, even though it may have some vulnerability in individuals with higher viral loads. More interesting studies that have been done to date have been looking at long-acting drugs in terms of their ability to suppress viral loads in treatment-naive individuals. The class of drugs for which this has been, long-acting agents have been developed, are the integrase inhibitors, in particular cabotegravir, which is now a third-generation integrase inhibitor, and an NNRTI, rilpivirine. Both of these have now been formulated in nano suspensions that can be given by intramuscular injection and have half-lives in that formulation that can last as long as 2 months. So this is now just looking at oral cabotegravir combined with rilpivirine as maintenance therapy, and an interesting study design looking at different doses of cabotegravir induction therapy, then moving on to cabotegravir plus rilpivirine as maintenance therapy in individuals who were treatment naive in comparison to fixed dose combination with an efavirenz containing regimen. And what you can see is virologic success was relatively equivalent across all of the cabotegravir dose arms, and was slightly better for the highest cabotegravir arm than for the efavirenz containing arm at 96 weeks in terms of virologic suppression. But this is, of course, cabotegravir with rilpivirine as a 2-drug regimen and the standard regimen of efavirenz with 2 nucleoside analogs. What I think is a more interesting approach here is taking this nanosuspension of long-acting cabotegravir in combination with rilpivirine, and again conducting an induction period with oral therapy, a single fixed-dose combination of cabotegravir, abacavir, and 3-TC for 20 weeks, and then randomizing patients to receive either cabotegravir plus rilpivirine given as an intramuscular injection once a month, given as an intramuscular injection every 2 months, or cabotegravir continued orally. And at the end of 32 weeks, another study that was just reported at the CROI conference, you can see that virologic outcomes were over 90% suppression or virologic success across all 3 of these treatment arms, and no significant treatment differences among them after 32 weeks on maintenance therapy, suggesting that a dose of rilpivirine with cabotegravir in this nanosuspension can be given by an intramuscular injection every 2 months and maintain virologic suppression out to 32 weeks for individuals in this study. So I think this is an important study to follow as we look for the future for longer-term duration in terms of how well this particular approach to long-acting therapy is going to, how well it's going to do virologically. Important points about this study: there was high patient satisfaction. There were appreciable rates of adverse events in terms of injection site reactions, but most of those were mild. They were limited to 48 hours, and patients, even though they had injection site reactions, were not dissatisfied with that. There was no clear difference in the dosing arms, no virologic resistance detected to the integrase inhibitors, and the intramuscular doses were comparable to a traditional oral regimen. So I think this is an interesting approach for both from the context of adherence in terms of assuring that individuals are getting good levels of drug and being able to maintain them with doses that can be given every 2 months. So the last drug I'm going to talk about is another new class of drugs that is starting to emerge into phase 3 clinical trials now. That's an entirely new class referred to as maturation inhibitors. At last year's symposium, I talked a little bit about this class of drugs, and just to show data that with a single second generation maturation inhibitor here, maturation inhibitor being the step in the replication phase of HIV just before the virus particle buds from the cell and starts to mature. This particular drug inhibits at that level, similar to protease inhibitors. And maturation inhibitors, when you look at an exposure-response relationship and a dose-response relationship, at the highest doses of this particular maturation inhibitor, you can see almost 1.6 log decline to 1.7 log decline in viral load after just a short period of time of 1 week of therapy. So I think that's a novel compound to watch for the future. So I'm just going to finish by summarizing that what's new in the guidelines are the recommendation that everyone be treated regardless of CD4 count. Newer drugs are now available in many parts of the world with improved activity and tolerability, and particularly integrase inhibitor-based regimens are starting to look like they are particularly good when administered first line in treatment-naive patients in terms of sustaining first-line therapy for prolonged periods with no emergence of resistance. And investigational drugs, there are several exciting new classes of drugs and novel approaches that are being tested in clinical trials. And one of the approaches we may see in the near future is the use of these long-acting drugs, either long-acting drugs given as nanosuspensions orally or intramuscularly or parenterally in ways that we haven't been used to give antiretroviral therapies before. So I'm going to stop there and entertain any questions.